Hello everyone. We're back again. Thanks for waiting. Hopefully you managed to get out and go bite to eat or drink. We certainly did. We've got plenty more coming ahead. After Simon, who's next, Gerhard Swinburne, Ananish Chaudhry, Jay Bhattacharya, Ramesh Thakur, and James Allen. So we're only a third of the way through. It has been fascinating. And in terms of Byron's presentation, just a little bit stunning. I was kind of lost for words in some ways afterwards. Thank you all for sticking in and around. Next up, we've got Simon Thornley. Simon is a New Zealand epidemiologist out of the University of Auckland. He'll be known to New Zealanders as perhaps the person who started the doubt back in March last year. And for a lot of people who had unease or concerns or questions, he coalesced them for many of us and has continued doing so through the past year in very effective ways. So welcome, Simon. Welcome on board. Simon's got a very interesting presentation about the existence of SARS-CoV-2 prior to Wuhan. And this is also topical because I think, if I'm right, in the past few days, there's been the report from the WHO that says that it didn't come out of, well, I think they said it didn't come out of a lab in Wuhan, but we also know it didn't even come from Wuhan. So, Simon, are you there? Are you live?
Yeah, can you hear me, Mark?
We can.
So okay, great. Okay. Look, thanks for having me, and it's great to have such a panel of luminaries, and I feel very humbled to be amongst this group. So here I'm giving a presentation which is really my own thoughts on this. It doesn't represent any group or organization, but my own, and trying to make sense of conflicting findings around the epidemiological evidence around SARS-CoV-2. So I'm going to just walk through my thinking process as an epidemiologist here. So here we go. The original story was that the deadly virus crossed the species barrier in Wuhan. However, there's a little bit of evidence that, well, there's some evidence that supports the theory, but there's also some evidence that contradicts the theory. The virus has been found before the Wuhan incident. So in light of that evidence, what does it say about our national policies? So let's just explore that. That's what I want to do in the next 15 minutes or so. And I can't help harking back to swine flu days, apparently very high fatality rate, clamour to keep out the infection. There was a response that was a little bit like COVID-19, but a bit more mild. We didn't do lockdowns, we didn't close the borders, but there was certainly a clamour to keep out the infection and to try and stamp it out. Then we had the sero survey, which showed a third of us had actually had the virus and we hadn't noticed. And so perhaps the virus wasn't quite as deadly as we first thought. So those thoughts did come through my mind when I saw COVID start to gather steam. Let's have a look at some of the evidence that was coming out of Wuhan. A new coronavirus was discovered. Okay, we've had SARS and MERS, the deadly ones, and however, 4 of them cause common cold-like virus, like illnesses. There was a respiratory illness with a characteristic radiological pattern, mainly in people who had cardiometabolic disease, as David pointed out. And there was some discussion about whether the virus had gone from bats to pangolins to humans, given the story of Wuhan. So what was the evidence that the virus crossed the species barrier there? Well, certainly 138 patients with respiratory illness and ground glass opacity on CT in a case series. Of 138, 57 were hospital acquired in the original case series. And quite a small proportion, actually, I was surprised to see, were associated with the Wuhan wholesale food market. In another case series, 50%, which was about 50 out of 100, 47 were employed at the market. So that was a bit stronger evidence. It is worth noting that the market is one of the biggest markets in Central Asia. So it's may not be that improbable that people visit the market, and actually a large proportion of people visit the market. It's not known what that exposure was. There's 90% homology in the virus between SARS-CoV-2 and SARS-CoV, hence the name, and there's a 99% homology to a pangolin virus, hence that theory. However, since that story came to light, there's also some other evidence that's come out that I'm sure many of us will be aware of. We also found out that the animals tested at the market were negative for SARS-CoV-2. In Spain, in March 2019, well before December, there was evidence of SARS-CoV-2 in the wastewater, which is like a ginormous sort of pooled laboratory test, indicating that it was likely to be in the community. So as an isolated finding, that could possibly be dismissed. However, in September 2019, well before the Wuhan incident, 11% of people undertaking a lung cancer screening study in various different regions of Italy also tested positive. In France, okay, so this is in December 2019, but a good month before the official case occurred, another person tested positive, and it wasn't known that SARS-CoV-2 was around. Likewise, in the States, between December and January, well before the first official case, 1% of people tested positive for the spike protein. So very interesting evidence there from several different sources stating that either the virus was there before Wuhan, or it was around before anyone knew about it. And it's just also worth thinking about the timeline here in terms of flights. This is flight volume globally, 2019, and this is 2020. So in terms of border restrictions and flight restrictions, they didn't really impact until early March. So one has to ask the question, given the Wuhan experience, did the virus wait for the PCR test to be developed and the virus to spread before lockdown, given that it was first discovered in December 2019, when there's obviously a high volume of flights, and it took 3 months to at least begin to stem the tide. So just being a fairly simple person, I want to put this in a timeline. Here we've got March 2019, the Barcelona wastewater study. Then we've got the Italy study, 10% positive, and the Wuhan incident in December, and then the first official case in Italy in February 20. So difficult to, there's different hypotheses. How do we tease between the two? And I think it's just worth reflecting a little bit on the philosophy of science that might help us here. In science, it is very hard to disprove a hypothesis. thousands of confirmatory observations are thrown out by a small number of contradictory ones. For example, if you say, well, water must boil at 100 degrees, you give your students the task of going out and testing whether water boils at 100 degrees, and everyone comes back with a confirmation. Their thermometer says 100 when it starts to bubble. Then somebody is a bit more adventurous, goes up to the top of Mount Everest and finds that actually up there water boils at, say, 60 degrees. Well, that one piece of evidence really casts a whole new light on what's been going on. And actually, the contradictions are sometimes more important than the confirmatory evidence. And that's from a textbook of epidemiology, by the way. When a virus is discovered, it is not that it is newly emerged, but rather that it is newly discovered. It's not clear how long the virus has been around. If we think about causal criteria, such as the Bradford Hill, it's important that, it's possible that one set of investigators may come up with some findings that are fraudulent. It can happen in medicine and science, but it's very unlikely that several different independent investigators are going to come up with the same thing. So what do I believe? I think my money is that it was around before Wuhan. Be very hard to make that up. It's not isolated. Cases were in September from a multi-region Italian study, and it wasn't low prevalence either. It was 10%. And just remember that antibody surveys in Spain after their big peak were about 5%. Now, we've the wastewater study, people are using this technique. Melbourne's not just threatened with a lockdown, they've actually gone into it for 5 days. Interesting that we haven't had any concerns about clinical consequences in the hospitals. Just as in 2019, there wasn't a song and dance about hospitals and intensive care units being overwhelmed. Important to think about some of the possible counter arguments. Some of them, well, could it have been around, but just very small volume of infection? Yes, but the nature of viruses, as Sinatra knows, with these models, is that they don't tend to just hang around at a very low level. If there's lots of susceptibles, then they tend to take off in an exponential manner initially until there's a certain amount of immunity, and then they die away. And remember, at that point, there was no social distancing, lockdown, border closures, whatever, if you believe that those are very useful. So what are the policy implications here? Well, the virus can be present in relatively large numbers and not overwhelm the health sector or lead to excess mortality. Elimination is unlikely if you've got a widespread virus and it's not really declaring itself in terms of clinical evidence of harm. And if you've got a situation with excess mortality from the virus, which, as we noticed, is quite proximally related to the input of lockdowns, it seems to me that that's a stronger possibility that some of this excess mortality, at least, is due to the response. And here's an example. So we've got 2019 excess mortality in Italy, and total male, female. That's when the study began. It was 2 or 3 months worth of samples before that. No excess mortality. Here's 2019 in Italy. Here's the excess mortality that everyone's seen. And this is where lockdowns started. And for anyone who wants to have a look at source there, it's there. So we've got this situation of competing hypotheses. Is it the virus that's causing the increased mortality, which I guess has been one of the things that we've all been arguing about, and the assumption, the mainstream narrative, is it's all been the virus? Or is it the lockdown, and does that increase mortality? And the notion that there's been SARS-CoV-2 around in 2019 and no one's noticed seems to make this a more stronger, favorable hypothesis. And so let's just think about now, how could lockdowns lead to excess mortality? Initially, it sort of seems everybody's being super cautious. So how could that possibly occur? Well, sometimes being super cautious can lead to very nasty consequences. So what we know now is, for example, there was very high mortality associated with mechanical ventilation in New York. Non-invasive ventilation was banned following WHO guidance and concern about spread of the virus. Now hospital mortality is dropped by 70% without really instituting any dramatic treatments, or new treatments. Steroids is really the only thing that's become mainstream. A few little concerning things was that there was, in the US particularly, there was very strong financial incentives to put people on ventilators. And I thought this would be very, very slow to come out, but there's a little bit of stuff on record now from intensive care physicians in Toronto. There are a lot of unknowns about the best way to manage this. Because the patient could deteriorate very quickly, the thought was to put them on a ventilator quickly to prevent deterioration. He recalls asking patients to get off their mobile phones so he could put them on a ventilator. He notes, but a candidate for a ventilator normally wouldn't be well enough to hold a telephone conversation. As physicians became more comfortable with COVID-19, many realized that early ventilation was not necessary. And it's not just in the US and New York that we've seen this. There's hospital mortality has declined precipitously, particularly in ICUs and HDUs, so places where people may be ventilated. So it looks like this has been quite an important factor. I think it's also interesting just to realize how much the effect on the hospital system in general occurred in terms of clearing out hospital beds. You know, in the UK, 30% of hospital beds were cleared. So that was 25,000 people sent to care homes. Reduction in emergency department use, 57% in the UK, comparing April 2020 with April 2019. Delayed cancer surgery, the average of a delay for 3 months for patients with urgent and need for urgent cancer treatment. Heart attacks and strokes went down in terms of hospital admissions, and so presumably the frequency didn't reduce, but hospital treatment did, and these were very proximally related to lockdowns. And just thinking about the big picture here, the age, what struck me very early on was the age distribution of death with COVID in New Zealand is basically the same as background death, which suggests that that COVID is not shortening lives dramatically compared to background risks, and it's totally different from Spanish flu. Where the mean age of death here, it's in the 80s. For Spanish flu, it was in the 20s. So what does all this mean? COVID-19, putting it all together, for me. COVID-19 was discovered in Wuhan, but likely already circulating in Europe and the US in 2019 without consequence. The earliest evidence was March 2019 in the Spanish wastewater study. So the response to this, when we're teasing out these competing hypotheses about what's caused the excess mortality, is it the virus, is it the response? To me, this strongly suggests that the response has led to the vast majority of excess mortality, and it's also exaggerated infection fatality rate given some of the early treatments that were likely to be harmful, and particularly excess mechanical ventilation. And that's led to an exaggerated need for vaccine and severe restrictions. There's also evidence increasingly compatible with COVID-19 restrictions causing harm and deferred care. So emergency hospital, emergency presentations, cancer surgery, heart attacks and strokes. And I haven't even touched on the economic or mental health costs that we've seen. And obviously 50,000 people go on the dole in New Zealand. 50 billion at least spent so far. Obviously these have consequences, increased anxiety disorders, particularly in children. So I think for me, given all this information, what's really necessary is political leadership, which is necessary to recognize some of these, this new information and to backtrack. So thank you very much for tuning in, and happy to take some questions.
All right. Thanks very much, Simon. Just want to point out to people that we're trying to ask all the questions that have been put up there, and in some cases we're pooling questions as well into one, but we're on some sort of summary, but we're trying to cover as much as we can. Simon, you covered the why didn't it escalate, but does because you're saying viruses will always escalate if it's an available population, which is, so why are you saying therefore that in 2019 the virus was operating at what you might expect it to be, or that escalation was there, the level was what it, back in 2019, what it was in 2020, and what it is perhaps now, that it hasn't changed?
Well, I mean, obviously the virus mutates, and there may be some changes in terms of severity. That's another possibility, I suppose, but unlikely to be so dramatic. For example, between the September 2019 and the December, and it just, a lot of, I think another aspect is, the 10%, that is a very high number. We know that, the prevalence of immunity and the prevalence of positive tests, as we've seen with viruses, that it tends to escalate up very rapidly and fall away, as Sinetra's elegantly shown with the SIR model, and it's been replicated in the statistics that we've seen with positive tests, that you get this very high spike and things go down. So, I mean, we have very limited information in terms of what happened in 2019, but we certainly, knowing that 10% of this Italian group in this cancer screening study from multiple regions of Italy tested positive, and it's been in the wastewater in Spain in March. It's certainly, is fairly compelling, and the fact that in several countries you've seen positive tests before the first case was officially recognized. And so, it leads you to think, if this virus was really around, would we have noticed? all these dramatic policies that we've done, which have really centered around a kind of idea that the virus was new in Wuhan, that we had to all protect ourselves from it, that it couldn't have been around before that time, such as border closures, elimination strategies. Does that make sense in the light of this data where it's been freely circulating in 2019 without any restriction?
Do you think that what you've counted or what you've accounted for could really make up for that number, or that number of excess mortality we think we're seeing around the world? I mean, because I think, well, if I understand it rightly, you're sort of saying mainly medical intervention is the key thing that led to the mortality. Do you think that really accounts for everything?
Well, I think it's very difficult to tease out and to be certain, and much of it really is comes down to a judgment call, and there is uncertainty. I've seen an interesting analysis that shows that that excess mortality really started in many countries very proximally to the lockdown. Obviously, it would be nice to do formal regression time series analysis to try and tease out, to what degree was it associated with the virus circulating, and to what degree was it associated with the lockdown. But seeing that there was so much, high prevalence in Italy at that time, no concern about overwhelmed hospitals. The details starting to emerge that intensive care doctors were panicked into overuse of mechanical ventilation. I thought that would be very slow to come out, but there are doctors who have put their name in ink and own those statements that yes, they feel they've made mistakes. They were frightened and overzealous about mechanical ventilation, and mechanical ventilation is certainly not a benign treatment.
No. What about people cases presenting with all the symptoms? I mean, that escalated as well, didn't it? How do we account for that?
Well, yeah, I mean, it's very hard to know what's happened everywhere in the world. There's certainly been stories where some parts of the world, I believe in Italy, that everyone who tested positive, whether they had symptoms or not, or whether they were ill or not, was sent to hospital because the authorities were so scared that they were going to deteriorate quickly, just as was spoken about in intensive care. And so, you've got to realize that much of healthcare is related to the demand that is created by healthcare policies. And it's possible to change policy, for example, test a whole lot of people and say, look, if somebody tests positive, they've got to be in hospital whether they are sick or not. And that can create, an overwhelmed healthcare system in itself. I mean, when I was a med reg, we used to take anyone pretty much in an adult age group who had chest pain. I always thought it was miraculous that we were not constantly overwhelmed, because there must be so many people in the city who have chest pain but just don't bother to report it. And thankfully for us, they didn't, or else we would have been constantly overwhelmed.
One final question. What do you think happened in New Zealand then? Because what I can see from your hypothesis is that it seems to fit the international format, but does that mean that New Zealand had the virus circulating and when we were getting it obviously for longer than we thought? And what does it mean for now, given that our and what does it mean for the? Actually, no, I've got too many questions there. Let's start with the first one. Does that mean that New Zealand had the virus before? We didn't just shut it down, and that we didn't just shut our country off and stop the virus coming in. We probably already had it.
Well, I think, that evidence that the virus was around in Italy and Europe, and the magnitude of the travel between New Zealand, Europe, China, before we locked down, it's very hard to believe that we haven't been exposed to the virus in quite a dramatic way. I know that we haven't done a formal sero survey in New Zealand yet. I'm desperately wishing that would be done. There's been some talk of researchers, I think, from the University of Otago doing that. But also we know that assessing exposure to the virus for coronavirus is not just about antibodies, that T cell studies from Europe show that there's likely exposure to the virus, which is only shown up through looking at that evidence. So it's a complicated thing to tease out, and whether it will ever be done in New Zealand, who knows? Obviously, I think it would be a way of testing this hypothesis further.
We're slightly over time, but I do want to ask. So, how does your hypothesis account for New Zealand's death rate, or our excess death, which we don't appear to have had here?
Yes, well, I believe we have done some things right in New Zealand that weren't weren't quite as dramatic with the healthcare response as overseas, and we've hardly had a lot of severe cases of COVID. We didn't send them all to hospital as happened elsewhere, and we were able to prevent nosocomial transmission within hospitals, and there was sort of segregation of patients, and I think that was a good thing. So yeah, I mean, obviously it explains what happens in some of the hotspots, but doesn't. Well, we did see some evidence of adverse reactions here in New Zealand from the healthcare sector. So, for example, the increase in maternal deaths that occurred in Auckland Hospital. So maybe there was some of these adverse reactions, but just in a more subtle way.
Mm. Thank you very much, Simon. That was an absolutely fascinating idea and thought, which, if it's true, means that it didn't start at Wuhan, but Wuhan and China seem to have set the format for what followed, which everybody copied. And be interesting to see what happens with your hypothesis over time, as we're all talking about, the history showing that perhaps this was the greatest cock-up there's ever been. Thanks, Simon. Right, moving on. Gerhard Sundborn, who's Professor of Public Health at Auckland University.